Welcome back to the Mindful Healthcare Summit. I'm Rihanna Hoffman, registered nurse, and I'm delighted to be one of your hosts. In this session, we'll be exploring racial equity in healthcare and examining how mindfulness can help contribute to a more just and healthy world. We're honored to be joined by Dr. Cheryl Giscombe, a psychiatric nurse practitioner, distinguished professor, and researcher with a PhD in social health psychology. Dr. Giscombe's research focuses on stress-related health behaviors and factors that contribute to health disparities in African Americans. She has recently completed an NIH-funded study on the cultural relevance and effects of mindfulness-based stress reduction for African Americans. From her long list of activities and accomplishments for this summit, I also want to highlight that she has been instrumental in bringing mindfulness training to nursing and medical students at UNC Chapel Hill, and she's developed an innovative curriculum to train MSW and psychiatric nurse practitioner students in providing more culturally sensitive care. Cheryl, thank you so much for being with us today.
Thank you so much. I'm really grateful to be here with you.
So to begin, obviously racial health disparities and health equity are huge topics, and we're in a very powerful moment in the history of the United States and the history of the world. It's been heartbreaking to witness what has unfolded these past months, and it's also been heartening to witness and participate in the calls for healing and justice, which has just reverberated around the world. It really feels like we're reaching some kind of watershed moment, and there's this growing sense of urgency in the wider medical community. There's so much to talk about, but to begin, I wonder if we could look at unconscious bias. Since the Institute of Medicine's groundbreaking Unequal Treatment Report in 2003, there's been this awareness and growing initiatives to address unconscious bias amongst healthcare providers, and it has steadily grown. And yet we know that even now in 2020, unconscious bias is still very much at play and still causing health and healthcare disparities. I know that you teach about unconscious bias, and I wondered, could you give us an introduction? What is unconscious bias, and how do unconscious biases among healthcare practitioners specifically contribute to healthcare disparities?
Again, thank you so much for having me with you today. I'm really excited to be able to talk about these issues that are so important to our world, to people, to human beings, to families, to communities, to individuals, and with the particular emphasis on our healthcare providers who are working so very hard to help our communities overcome these traumatic experiences related to COVID-19, and also those people who are helping in our communities to help people cope with all the other tragic losses. I think people are dealing with a great amount of suffering at this point, and we know that, as long as we are alive, suffering is inevitable. It's also, as you started to mention, or as you alluded to, an opportunity for healing, an opportunity for compassion, an opportunity for us to be more aware and, as we say, mindful about how we interact with others and about how our perspectives are shaped and how they influence the lives of others. So I first learned about unconscious bias or implicit bias, I think, when I was a graduate student in social and health psychology, and became aware of those different types of assessments, like the implicit bias testing, the various ways people can try to determine if they have implicit bias. And, it's easy really when we consider that we all have to some degree, some type of bias towards all kinds of things. We can start to think about how, in some ways, we all as human beings want to be more efficient in our lives. We all want to not have to expend a lot of cognitive energy to make everyday decisions. And so our brains are set up to categorize, to differentiate, and to automatically respond. And so it can be a very helpful thing. Example is when you go to the grocery store and you want a certain type of product, and because you use it so often, you don't really read the labels. You know what color the box might be, or if you're shopping for detergent and you know what color that container may be. And so our bodies, our brains are automatically set up to be efficient to select that item, so we can be in and out. Our bodies are efficiently set up to protect us from what we might consider harm or danger. And so if we've received messages or information that something or someone may be harmful, we have this efficient processing that allows us to protect ourselves. So it's set up for efficiency. But just like a lot of things in life, things that can be there to help us can also be a source of challenge, or can be a double-edged sword, so to speak. And it's the same with biases. And so we often in psychology refer to that as heuristics. So when we have these cognitive shortcuts that allow us to be efficient, but it can also cause us to be biased against individuals when it's not warranted. It can cause us to have what is known as stereotypes, where we have assumptions about people that do not allow us to look at people as individuals and work with people as individuals, but we lump them together based on what we assume or think they may do, or things that they may represent. And that's where the challenge is. And if we as individuals can become aware that our brains, on one hand, operate in that way to help us, but that it's also potentially problematic, that initial step of awareness can enable us to realize that we may want to do something about the problems that these implicit assumptions or these implicit biases may cause. So I'm glad that we're having this conversation to help your listeners, to help the viewers understand more about what they can do, and how they may change themselves, or at least become more knowledgeable about themselves, and then how they may be able to help others.
Cheryl, thank you so much for that. It feels like a really helpful ground to begin. I know that looking back to my own experiences in nursing school, I'm an emergency room nurse now, we were taught to memorize sets of facts about what diseases and conditions impacted different groups of people, and it was broken down by race. So African Americans or Black Americans were more prone to develop these diseases. Indigenous people of the United States were more prone to these diseases. Interestingly, there was less information that we were asked to memorize around what diseases white people were prone to develop.
Yes.
And hearing your response just now also makes me realize that it's actually ingrained in at least my experience of my medical training to develop these kinds of biases that can easily become racism.
Yes.
Which I hadn't thought about before.
Exactly. Racism, discrimination, prejudice, and even oppression. When it may not be race-based, but it may be some other group that is vulnerable to oppression. But specifically speaking of racism and what you described, I had the same experience in nursing school, and many healthcare providers will somehow identify with the term pattern recognition, where we're learning about symptoms and how they cluster to create certain, or to be, they're identified with certain conditions, or just as you so well described, when we learn about what we might expect to see in certain racial or ethnic groups. And I think that was meant to help us not overlook certain conditions in those groups. But what it ends up doing for many is biasing us to not see an individual in front of us, but we see the race or the ethnicity and we are in a mode of efficiency, meaning we have limited time, limited resources. We need to act and develop an assessment, a diagnosis, a treatment plan, and then we might have a faulty assumption. And I can give an anecdote. I've shared it before with others, but a really, I think, illustrative example is an experience I had with my grandmother, who's now deceased, who called me, or actually I called her, and she was 91 years old at the time, living by herself because she insisted upon it, and she was a retired nurse, and she was having symptoms like GI distress, nausea, weakness. I called her and she told me she was having these symptoms and could not reach other family members or friends. And so I drove literally over 2 hours to, check on her because she didn't feel that she needed to call 911. She wasn't strong enough to drive herself. So I went to her home. She agreed to allow me to take her to an urgent care facility. And by the time I got to her house, her neighbor asked us where we were taking her. Her neighbor had gotten home, and she said, well, at that place, they don't understand us. They don't know anything about us. And I knew what she meant by that. My grandmother's African American. Obviously, I'm African American. She lives in a community that's predominantly African American, and it made me assume that what she was saying was whoever provided care at that urgent care didn't understand African Americans. But that was where my grandmother insisted she wanted to go. And so we walked in, 2 nurses, and we got to the counter, and there was a provider, and I won't, could be nurse practitioner, physician, PA. I don't want to say which one because it's not really about that. It's about the fact that it was a licensed healthcare provider and the medical assistant. And we explained the symptoms that my grandmother was experiencing, and that person said, I don't have time to draw labs now. We won't get the results today. But what you should do is go to the drugstore and get an antacid and cut back on fried chicken and greasy foods. Yes, that person literally said that to us. My grandmother was so unwell that I didn't have time to go into a back and forth with that provider. I did explain that was inaccurate, that wasn't even part of her diet. The medical assistant, saw the value of suggesting that we go to the emergency department. And ultimately, my grandmother had a number of tests done, and she was actually diagnosed with metastatic cancer. And actually, she passed away within a month. So she was deeply ill. But that person saw 2 African American women in that particular neighborhood and thought that the issue was too much greasy food and fried chicken. Now, that is a really good example of bias. And people may say that's not even implicit bias, that's explicit bias. But it is bias based on that person's stereotypes and assumptions that somehow developed, that somehow this person felt they didn't have enough time or didn't value the fact that there were 2 people in front of them with these symptoms, my grandmother with these symptoms. But for some reason, he felt that he didn't have time to do more proper assessment, testing, and suggested she go get an antacid. And so when that experience happened, again, I didn't have time to address it then, but I promised myself that because I am a faculty member who teaches healthcare providers, students who are seeking to be healthcare providers, that I would never let that example go to waste, that I would share that example so students could see how bias works and how assumptions work. And you can really try to dig deep and think, well, what may have made a person to say that? Did he feel too busy? Had he had a lot of experiences with African Americans who had these conditions, and it was because they ate, you could just kind of try to have a little, not that what I want to say is, it's one thing to get angry at that person and to say they were neglectful. But then it's really important for us to think about what happened and how can we prevent that. And so you mentioned that I teach mindfulness. I teach it with a colleague in the School of Medicine at UNC Chapel Hill. I'm in the School of Nursing, and we work together to teach nursing and medical school students mindfulness. And when we teach mindfulness, we teach traditional mindfulness. We teach it following the MBSR model, and we also expose the students to research on mindfulness. And we've started to expand that curriculum in that course to include more information about how mindfulness and other reflective and contemplative practices can be used to help students better understand what they're bringing to a patient-provider encounter. And hopefully they learn more about understanding themselves, understanding that there is time in each moment with patients to meet that patient where he or she is, time to understand the patient's context or that person's context, and that's going to inform quality care, because these are real people and they're real results if we lean too far into our biases. Biases are part of being human, so I don't think we're ever going to completely erase them. What we want to do is be aware and overcome the limitations of our biases, because as we mentioned before, biases can be helpful. They can help us be efficient. You may have members of a healthcare team who, one is from the Northeast, one is from the Southeast, one is from another country outside the United States, one is a physician, one's a nurse, one's was raised on a farm, one is raised in a city. And so you have a team, and the biases, the information, the experiences that each one of those team members has can actually help build a powerful group of individuals who can help a patient or help a family to get through conditions, because we see the situation from different perspectives, and we help each other with our blind spots. So we don't ever want to lose what we bring to the situation. We just want to make sure that what we're bringing to a situation doesn't hurt someone else.
Wow. First, thank you for the story that you told of your grandmother and for honoring her and that experience. And I'm also wondering about some of the, let's say, scientific research or research in general that's been done that illustrates the prevalence of unconscious bias in healthcare and quantifies some of its effects on patient outcomes. And so the story that you shared is some of that. I'm also curious about the research. And I'm also curious what you think that white clinicians can do to become more aware of their unconscious bias that I know that, I as a white person and a medical practitioner do hold.
Yes, thank you so much. Such powerful questions. And I'll start with the second one. I think what a white person or a white clinician can do really depends a lot on how they're educated. Of course, each individual needs to be responsible for him or herself, knowing that you're taking an oath to provide quality care to individuals, families, and communities. And you're dependent upon schools, programs, institutions to give you an education that's going to challenge you beyond what you already know. And so the most efficient thing we can do as educators of future healthcare professionals is ensure that our curricula include content to address implicit bias, stereotyping, racism. Public health, of course, goes beyond individuals, and so the curricula should also include making sure that students understand socio-ecological frameworks, biopsychosocial processes. So an individual might show up a certain way, But why did they become that way? What in their context created the dynamics that we see now? People are way more than what we see in front of us. And so what, in addition to what institutions and schools can do, is what the individual can do is what you asked is, how can we be as healthy as possible so we can help others be healthy and as healthy as possible. So if we are stressed, if we're burned out, if we're distracted, if we're depressed, we're not going to be able to give as good care to others. So when healthcare professionals take an oath to care for others, they also should be taking an oath to care for themselves, because that is going to directly impact how they interact with patients. But it goes further than that, because healthcare professionals work in systems. And so an individual can want to be as healthy as possible, but if that system is not promoting wellness for that professional, then they're in between a rock and a hard place. So there's so many levels of responsibility. The individual, the institution that educates that individual, and the institution that in which that person works. And even if it's a private practice, what is the vision? What's the philosophy of that practice to ensure what is known as the quadruple aim? We know about the triple aim of healthcare, which is to ensure that patients are satisfied, that patients achieve quality health outcomes, and that the care is as cost effective as possible. And that fourth aim includes making sure we're also taking into consideration the experience and or well-being of the provider. And so when healthcare systems don't look at that fourth aim, they're actually fiscally and morally inefficient. And so, but it's the fiscal part that will probably motivate institutions to integrate provider well-being in their practices, in the way they run their systems, because it will affect turnover and burnout, and that's a very expensive thing for providers, but it will also trickle down to affect patient readmission, longer hospital stays, multiple chronic illnesses. So this is a moral issue, it's a health issue, but it's also an economic issue. And so that's a great thing, actually, because that's the thing I think that will help people to see no matter what anyone's orientation is, they're oriented to either one of those three things: moral, healthcare, or finances. And so there's something there for everyone. So I think it's something that everyone can embrace.
I was just thinking a big yes to that last piece that you were saying.
Yes. And the evidence, you mentioned research. I mean, there's so much research to support everything that we are talking about. The implicit bias research is, it goes way back in social psychology, cognitive psychology, now healthcare, research on prejudice, discrimination, the research on contemplative practices, mindfulness, reflective practices. That's more recent, but over the last 30 years, we have so much evidence of the benefits of that for individuals and for healthcare providers. And then, of course, the fiscal data that we have demonstrates how expensive it is to orient and employ and orient a new provider, and if that provider doesn't stay, the cost of that and how much more it takes to find someone new and train them again. And of course, we don't want the cost of people getting sick and staying sick, and it's just a cascade of events that can occur. So we have the evidence we need to do something differently.
I feel like one of the things that comes up for me is that ideally, as we as clinicians and medical practitioners become more aware of our implicit or unconscious biases, whether that's through our own motivation to do our own sort of inner work and look at what's happening for us in our own work settings and healthcare settings, or something is actually brought to us, like you were saying, through our system. Many of us are out of school now, and so it's about what a system or an employer provides for us in terms of education on these things.
Yes.
So, and I feel like as we become more aware of those implicit biases, however that educational process happens, that we would then be able to provide what you and others have called more culturally sensitive care. I'm wondering if you could talk a little bit about what culturally sensitive care means for you and how can we practice it?
Yes, thanks for asking about that too. One of the previous terms was cultural competence, and that term is not as popular anymore because we recognize that no one person is going to be competent on cultures, on people from different cultures. Competence, represents, that you are 100% precise, with understanding or knowing what someone else's background is. And it's a consistent pursuit. And so your term cultural sensitive, another term is cultural congruent care. Cultural humility is another term that's important. And it's about us recognizing that number one, we don't know it all. We see a person in front of us and they may represent what we think we understand what that represents, but there's so much more to a person than what we see or what's on the outside. And cultural sensitivity or cultural humility means that we are willing to understand that what we don't know, and that we try to develop rapport with the patients to whom we provide care, so that they, number one, feel safe with us, so that they trust us enough to answer questions as honestly as possible, and that they allow us to understand the nuance of their lives so we can take that into consideration as we're assessing and working with them. So we're not giving them a treatment plan, but working with them to develop a plan of care that will match their needs as much as possible. And so humility on every level, cultural, racial, and just, the fact that there's another human being in front of you, having that humility to recognize the sacredness of the encounter. And even if we've done it 1,000 times, that actually may make us feel like, I've seen this before. I've got it. I can be efficient. And we want to be efficient. I don't want to dismiss the importance of efficiency, but mindfulness, reflective practices, those kinds of things can actually help us use the space and time that we have efficiently, as well as make that point of contact, that connection with a patient or a person that enables us to know more and respect more and cover a lot more ground and achieve, I think, the goals we aim to achieve to promote health and well-being.
I feel like some of the things that you're speaking to are connected to how it is that we as practitioners hear our patients and listen to them.
Yeah.
What does that sort of like genuine listening actually look like, or how is that practiced? And I know that I hold that question, especially as an emergency room practitioner, where it feels like there's never enough time to barely do the sort of practical things, let alone deeper listening. But for any of us who work in healthcare, can you speak a little bit about this notion of intentional communication that you've spoken about, and
Yes.
intentional listening, the notion of like listening to respond versus listening to hear?
Oh, yes. And you're exactly right. Like checking in with our intentions. Moving from situation to situation, meaning like from one patient to the next, even in an ED setting where there's so much busyness, so much, for lack of a better term, noise, so much activity, so much stimulation. And so it could be easy to carry, from one experience to the next, and you're not fully present with that particular patient. But developing practices where you can learn how to check in with yourself, even in a brief 15 seconds, 30 seconds, 1 minute. What can you do to check in with yourself, release the experience you just had, and then be present with the next experience? It's possible. The other thing that's important for us to remember is that we do have colleagues. We do work in interprofessional and interdisciplinary teams. We don't have to do it all ourselves. And so practices that help us to remember the value of our team members, and that we do what's in our realm, but that we can call on other team members to cover the next thing. So if we get enough information to recognize that this person needs a referral, or this person, you can call over a colleague to help you, because it's also about the fact that none of us is perfect and none of us can meet everybody's needs, and we don't have to, but we feel that we do. And so if we recognize, where our limitations are, so then we can pull in a colleague or discuss this within a team. But then that means we also need training and education on how to provide the best team-based care, how to communicate efficiently with our team members. So it's communicating with the patient and their family, but it's also about how do we communicate with our team members so that we are hearing them, they're hearing us, we're valuing. Sometimes if a team member has a divergent perspective, then people may dismiss it, but it actually may be that different perspective is exactly what's needed to help us all think on a higher level. And so I love to use reflective practices and contemplative practices, even arts and humanities, to help individuals see the potential that teams can have in not only providing high quality care, but in releasing or reducing the burden of any individual who's a member of that team. But just like how we want our patients to trust us, we need to feel that we can trust our team members and we can rely on them. So thankfully, I think medical education, nursing education, health professions education is moving forward to rely more on interprofessional education, so people can learn more about how to work with teams before they are actually working with teams in the real world, in the real patient care setting.
Thank you for that, Cheryl.
You're welcome.
That feels like I feel excited to be in medicine, hearing some of these things that you just spoke to.
I remember when I first, I'm a psychiatric nurse practitioner, and there are certain medications that we learn about prescribing that we, all medications, we need to be cautious. We need to have caution and understand, the implications of prescribing them. But there are certain medications that stand out that you are extremely cautious about what we say, start low and go slow, because you don't want to cause, unintentional reactions or side effects or interactions with other medications. And so there was one particular medication that I thought, when I learned about it in school, I think I'm going to try to avoid ever having to prescribe this medication, because there's just so much about this medication that requires a lot of caution. But of course, sometimes it is the right medication for the person. So I remember the very first time I needed to prescribe that particular medication, I was extremely cautious, provided a lot of education to the patient, but I still went home feeling actually like I couldn't sleep. But I didn't have to have that, because I picked up the phone and I called a 24-hour pharmacy. And what I learned is that pharmacists love to educate. They're underutilized. They have so much knowledge. They're more than, what people think they do. They know so much. And so I called the pharmacist, and it was probably 11 o'clock at night, and told him the situation. And I told him exactly what I did, exactly the education I gave the patient. And he just was there to reassure me that you did exactly the right thing. And if you know, and then we talked about if-thens. That was the very first time. It was probably just a few months out of, after passing my license exam, and I had supervision. I was working with colleagues, but I still went to bed with this, heaviness. And so that helped me to see how powerful it is to have relationships with other colleagues. And so the pharmacist that I worked with more on a regular basis during daylight hours, I worked on Mondays and Fridays, and so I'd call him on Fridays about different things. We developed a professional relationship. And when I call and he said, "Is this Cheryl?" I said, "Yes." He said, "Must be Monday or Friday," because, and sometimes I wasn't calling for advice. I was just fostering a relationship, because my patients would go into his pharmacy. It was a private pharmacy. And so both of us had eyes on my patient, our patient. It wasn't my patient, it was our patient. And so that gave me assurance that, I can rest because I'm not the only person who cares for this patient. So those type of interprofessional relationships are so invaluable. There was a lot of kindness, a lot of mutual respect. And sometimes we get so stressed, so burned out that kindness, the patience with one another, even the openness for what others have to offer, we miss that. We miss out on those opportunities. And not only do we suffer for it, our patients might also. So, if you initially talked about all the things going on in the world today, and those opportunities are there not just for healthcare providers, but they're there for us all if we only allow ourselves to see that there's a lot of beauty and potential in human interactions. It's still there. I know a lot of us at this point are, sometimes it can be discouraging, but it's not gone. It's still there. And I keep mentioning mindfulness and reflective practices. Those things can give us the wherewithal to continue to be hopeful and to continue to be optimistic about others.
Cheryl, are there specific mindfulness or contemplative practices that you teach to students and to professionals to help understand these topics? And is there one or two that you could lead our summit audience in doing now?
Sure. There's several that, my colleague and I teach to our students in the schools of medicine and nursing. And we follow the tradition of MBSR, mindfulness-based stress reduction. So we teach things that are, from the fundamental raisin tasting experience to body scan meditation, basic sitting meditation, walking meditation, meditation of sound. One of my favorites is the mountain meditation, where people visualize themselves as a mountain. There's a meditation called Leaves on a Stream, which helps people, with meditation or with mindfulness in particular. We're aware that our thoughts are always present, and some people think they have to push their thoughts away. But, we can think of our thoughts as leaves on a stream and just gently allow them to move along the waters peacefully and slowly, and bring our awareness back to the present moment. So as, we close, I'd be more than happy to lead a brief meditation. And generally when I meditate, I have to ground myself because I'm very busy, and I'm sure a lot of people are extremely busy. So I usually have to ground myself. I usually have to take a few moments to really notice what I'm sitting on, be it a chair or a bed or the floor. And so if people are sitting on a chair, first they may feel comfortable closing their eyes or allowing their eyes to just rest and be not focused on any particular thing in front of them, but just to cast downward or simply close. And you may just be aware of your own personal breathing, not changing your breath at in any way, but just being aware. And for some people, it may be helpful to take a few deep breaths. And often what's recognized as helpful is breathing in through your nose and out through your mouth. And if it's helpful to do that 2 or 3 times. But I think it's important to encourage people to breathe in the ways that feel best for them. But in grounding oneself, you can notice what's holding you up. So if you're sitting on a chair, recognize and allow that chair to do what it's there to do, which is to hold up your weight. It's there to support us. And so you might notice your hips in a chair and allow your bottom and your hips to just relax a bit more deeply into the chair, letting that chair do what it's there to do, which is support your weight. And if you notice any tension in your upper thighs or your hips, just seeing if you can allow that to be released or even melt into the chair. Checking in to see if you're holding your breath and releasing if you are. And then also noticing your feet and whatever your feet are on, whatever surface your feet are on, allowing that surface, be it the floor or whatever your feet are resting upon, allow that surface to do what it's there to do and hold up your feet. So if you're noticing any tension in your feet, just allowing them to relax, come down a few notches and just relax and release that tension or energy and let the floor do what it's there to do. And again, checking in, see if you're holding your breath. It's amazing how easy it is to notice that we're holding our breath or not breathing deeply. You might even want to bring a slight smile to your face because that kind of helps us relax our muscles in our face. Noticing our jaw to see if we're holding any tension there. Taking a moment even to notice your cheekbones, your eyebrows. Noticing even if you can without looking your forehead area and just seeing if you can bring some tension release there. And gently allowing your awareness to scan all the way to your toes. And at your own pace in silence, just gently becoming aware of each area of your body as you move up from your feet to your ankles, your legs, upper thighs. Checking in again to see if you've allowed any tension to come back in your hip area, and again allow that chair to hold you up. Noticing your back, allowing your posture to be comfortable but erect. Noticing your belly. Remembering to breathe and perhaps even remembering to smile. Moving up to your sternum area. Noticing and appreciating your shoulders. And again, gently scanning the area around your face. Remembering to breathe. Circling your entire head as you reach the crown or the very top of your head. noticing the presence of your entire body with gratitude. And when you're ready, perhaps starting to stretch or wiggle your fingers, perhaps even stretching and circling your shoulders. And if your eyes are closed, gently allowing them to open. Appreciating this time and this opportunity to be together today. Thank you.
Cheryl, thank you so much for being with us today and sharing some of your personal experience and also research that you have done and are engaged in, and also hearing these little snippets here and there about some of the hope that you have for not just the future of medicine, but this notion of opportunity right where we are in the sort of thick and mess of many things right now. So just thank you so very much.
Thank you. Thanks so much.